I'd like to introduce Dr. Brett Schipper. He's a surgical oncologist, chief of surgical oncology at Hartford Healthcare in Hartford, Connecticut. Dr. Schipper, would you explain to us a little bit about your Hipec program at Hartford?
Sure. Good evening, everybody. Thank you so much for joining us tonight. So I've been here with Hartford Healthcare a little over 9 years. I did my fellowship training at the University of Pittsburgh, which is a very big center for Hipec. And when I came to Connecticut, there was really very little Hipec going on. So I started the program at Hartford Hospital, as well as another hospital in town, and have been running the programs here ever since. We have a very large multidisciplinary program involving medical oncology, surgical oncology, radiology, pathology, where all of the potential Hipec cases are presented at the multidisciplinary conference. This allows many different eyes to review the cases and ensure that Hipec is really the best option for these patients. Once they're selected for Hipec, then we have a very well-rounded team in the operating room that has specific anesthesiologists as well as perfusionists and OR teams that are dedicated and trained specifically for Hipec.
Dr. Schipper, question coming in. Who are candidates for Hipec?
Sure, that's a great question. So there are a few different candidates for Hipec. So we use Hipec for patients with metastatic cancer of different varieties. Some of the most common types we use are for things like appendix cancer, colon cancer, and ovarian cancer, as well as other things like pseudomyxoma peritonei, which sometimes can be from appendix cancer, but could also be from primary peritoneal cancer. And then there's other studies looking at things like gastric cancer as well.
Okay, obviously this involves surgery. How long is the surgery for a patient that decides they want to get Hipec?
So every patient is different. It really depends on the amount of disease that the patient has in their abdomen. Sometimes I do Hipecs for patients with very low volume disease, and the surgery may just take a few hours. However, there are other times I'll do the procedure for patients with large volume disease. And sometimes we can be in there for up to 10 to 12 hours, being meticulous in trying to remove every piece of cancer we can see. Once we've removed all the visible cancer, then we use the heated intraperitoneal chemotherapy to try and kill any cancer cells that may be left floating behind. So it's really hard to predict how long your surgery will be until we actually get to the operating room. The CAT scans can sometimes give us an idea of the amount of disease in the abdomen. However, they frequently underestimate the true volume of disease. And there are many times where we get into the operating room and there's certainly more disease than we expect.
Okay. Now, when you talk about administering the chemotherapy, is this chemotherapy directly into the abdomen, or there is any systemic chemotherapy? Are there any side effects of the chemo?
Sure, another great question, thank you. So we use two main chemotherapy agents. We use mitomycin C for most of the GI, like colon or appendix, and we use a platinum drug for the ovarian cancers. The mitomycin C is very well tolerated. There were really little to no side effects. The platinum drugs are somewhat more toxic to the kidneys, so we have specific protocols in place to make sure the kidneys are well hydrated and continue to function at their utmost potential to avoid any renal toxicity. The chemotherapy is out of your system within a few days and has very little actual systemic transformation from the peritoneal cavity. The chemotherapy is given directly into the abdominal cavity. It is not given into the bloodstream like standard systemic chemotherapy. This is given into the abdomen. The abdomen is then closed and the chemotherapy is circulated around the abdomen for 90 minutes. During that 90 minutes, it's hooked up to a perfusion machine, which circulates the chemotherapy at about 1.5 liters a minute and heats it to approximately 41 degrees centigrade. At the completion of the 90 minutes, we then drain out the abdomen and then reopen the abdomen to complete the operation.
So there's very minimal side effects, so there's no hair loss or anything of that nature then?
Absolutely. None of those effects like you would get from standard chemotherapy. Again, aside from the potential renal toxicity of the platinum drug, but again, as long as you're very careful and take the appropriate safety measures, the side effects are quite low there as well. The side effects from Hipec really come from the debulking or removing the cancer. The more debulking we have to do, meaning removing organs such as small bowel, large bowel, spleen, parts of pancreas or stomach, The more debulking we do, that's where the risks start to increase.
Okay. Another question from our audience. What is a must removed organs? In other words, what organs must come out during a Hipec procedure? How is that determined?
So it varies again on why we're doing the procedure. So for instance, if we're doing it for an advanced appendix cancer, we would certainly always remove the, always remove the appendix as well as the right colon where the appendix plugs in. If we're doing it for ovarian cancer, we would certainly always remove the ovaries. We certainly try and leave as many organs as possible and only remove what we have to. Sometimes we're able to use devices in the operating room and peel the cancer off of the organs so that we don't have to remove the entire organ. Unfortunately, other times there's just too much disease and it's too deep into the organ to be removed, and we have to remove the entire organ.
Okay. Another question coming in addresses a laparoscopic Hipec versus a regular Hipec. Are both acceptable? What is the difference between the approaches?
Yeah, so and another great question. You know, in today's day and age, everything's moving toward minimally invasive surgery. And we certainly offer laparoscopic minimally invasive Hipecs here as well at Hartford Hospital. It really depends on the amount of disease. I tend to limit the laparoscopic approaches for patients with minimal disease burden. And for a very early appendix cancer, a laparoscopic approach is perfect. We can go in through minimal incisions, remove the appendix, remove the right colon, try and remove, you know, the minimal cancer that may have spread, and then through some slightly larger incisions, place our cannulas for the heated intraperitoneal chemotherapy. Unfortunately, if patients have a very large burden of disease, it becomes quite difficult and sometimes impossible to really do it in a minimally invasive fashion.
Okay. During a Hipec and after the Hipec, what is the hospital stay normally?
So patients, I tell patients during the preoperative consent process that it's about an average of 7 days in the hospital. Now, again, this can vary greatly. One of the major side effects of Hipec is the intestines from the heat of the chemotherapy get stunned, and they get what's called an ileus. An ileus just means the bowels go to sleep and stop functioning. That ileus can last anywhere from 1 to 2 days to 3 or 4 days. And that's what really determines how long you're in the hospital for. If your bowels wake up quickly, then you can be out of the hospital in a shorter period of time. If your ileus lasts longer, then obviously you may be in for a longer period of time. But I'd say on average, it's about a week.
Okay. Say a patient goes through Hipec, and how many Hipecs can a patient normally go through? In other words, if the disease come back, will you do another Hipec?
Yeah, so that's another great question, and absolutely, I certainly have many patients who we've gone back and done a repeat Hipec. I try and have the patient at least have show some durability from the Hipec. So if the disease recurred in 6 months, I probably would not offer them another Hipec. However, if they've made it out a few years and they did great, and now there's just a minimal recurrence, absolutely, we can go back and redo the Hipec again. That's not uncommon for some of the low-grade mucinous appendix cancers. Sometimes they do come back in a more less aggressive way, and we certainly can go back and do it again. Now, it does get a little more complicated the next time we go back, because during the first time, we've presumably removed some of the organs already. So there becomes less and less organs we could potentially take out as we go back each time, because we really strive to get what we call an R0 resection, or removing all the cancer. The data really shows that the Hipec works best when we can remove all the cancer. The more cancer we have to leave behind, the less efficacy we get out of the hot chemo. So we're really very aggressive to try and remove all the cancer.
Would you be using the same chemotherapy at this point in time?
Yes, absolutely. Still the same, for the GI, the mitomycin, and for the ovarian, or another disease called mesothelioma, we tend to use the platinum drugs.
Okay. On a repeat Hipec, is laparoscopic more of an option than in the original Hipec?
Usually not. One of the side effects of a large operation like a Hipec is you can stir up a lot of scar tissue. So when you go back, especially if the first operation was an open operation and we did a lot of work, the body's going to develop a lot of scar tissue. And those tend to be a lot more difficult to go back in a minimally invasive fashion the second time. So for a repeat Hipec, more than likely it's going to be an open procedure.
Okay. Say a patient goes through a Hipec surgery, what is the general amount of time to recovery where they feel good that they can go back to work and resume their normal activities?
Yeah, so, again, it somewhat varies. So for instance, for a patient, as we've been talking about, who we do a laparoscopic, minimally invasive Hipec, they may be back on their feet in a few weeks. They have minimal small incisions. And if we haven't done a lot of debulking, then they can be quite active soon. If it's a large abdominal laparotomy, which means completely opening the abdomen, and we do, a fair amount of debulking, I usually tell patients it's really about 2 months before you really start to feel back to yourself. I tell most patients to take about 8 weeks off of work, but more than likely they'll be able to go back sooner. I'd much rather patients have a little bit more time off and be able to go back sooner than underestimate the amount of time and then get in a difficult situation where they're forced to go back. But I certainly have plenty of patients who after about 4 weeks are ready to go back to work and do just fine.
A question coming in from our audience: is it an option for a patient to select their chemotherapy for a Hipec?
Again, typically not. There's a lot of work that has been done over the years to really pinpoint the chemotherapies that we should use. For instance, for appendix cancer, there has been, a consensus amongst the physicians who do Hipec to use mitomycin. So, the mitomycin is very standard for the GI. There's a little bit more variety when you're switching to the platinums. For instance, for mesothelioma or for ovarian cancer, there are different platinum drugs, the cisplatin, carboplatin, these different varieties that can sometimes be used. But for the most part, no. Unfortunately, the patient usually is not able to just pick their chemotherapy.
As far as the chemotherapy is concerned, how long does a patient have to be off chemotherapy before they can go through Hipec, or do they have to be off chemo to go through Hipec?
So yes, I usually like my patients to be off of chemotherapy for about 3 to 4 weeks beforehand. Typically, if a patient is on chemotherapy, sometimes their immune systems are down, they're weak, they're fatigued. So I like to give their bodies a chance to kind of rebound, get stronger, so they can go into the Hipec, ready to rock and roll in full strength, full nutrition, and full energy to get through it safely.
And as far as the chemotherapy is concerned, do patients go back on chemotherapy after Hipec, or is it an individual basis, or how does that work?
Yeah, so that's another great question. And again, it somewhat depends on the cancer. So for instance, if I have a patient with a low-grade mucinous neoplasm of the appendix, and I get in and I'm able to remove all the disease, and we do the heated intraperitoneal chemotherapy, for the most part, those patients will not receive any adjuvant chemotherapy or chemotherapy after surgery. However, if we have to leave disease behind, or for other diseases like ovarian cancer or mesothelioma, then sometimes, yes, patients do still require chemotherapy after the Hipec.
Okay, another question in from our audience is, what is the recurrence for LAMN after Hipec for appendix cancer?
So if you're able to remove all the disease and you do the Hipec, you can make it for a low-grade mucinous neoplasm. You can go years, without a recurrence. I certainly have patients that are years out from their initial surgery with no evidence of disease. It gets a little bit, the disease-free interval changes somewhat as you go up in aggressiveness of the cancer. So for instance, a higher grade or a signet ring cell disease, they certainly may recur quicker. But for the low grades, they certainly have the potential to go years without a recurrence.
Okay, another question coming in: what happens if the cancer comes back down the road?
Yeah, so if the cancer comes back down the road, as we mentioned, we certainly, if it's far enough down the road, we can certainly offer another debulking and heated intraperitoneal chemotherapy treatment. If for any reason the patient is not a candidate for that, being maybe they're too old or they're too sick or they have other medical problems that would just prevent it, then the best option we have at that point is usually systemic chemotherapy. But unfortunately, for a lot of these diseases, systemic chemotherapy doesn't work as well. The systemic chemotherapy has a difficult time penetrating through the organs to get to the cancer, because these cancers coat the organs. They live on the surface. So the chemotherapy sometimes can have a hard time penetrating. That's why the heated intraperitoneal chemotherapy works better, because it literally bathes the organ in the chemotherapy.
Okay, another question from our audience: what is the most difficult places for recurrent disease after Hipec? Where does it normally come back?
So it can really come back anywhere. There's really no rhyme or reason sometimes as to where the cancer can come back. It can come back, locally where it was the first time, or it can come back anywhere. I'd say frequent places are sometimes over the right side of the abdomen, over the liver, on the diaphragm there. There's sort of a natural circulation in the abdomen of fluids, and that's a very common place for disease to land. It's not uncommon at all during a debulking that we have to strip the lining of the abdomen on the diaphragm to remove cancer from that location. But really, it can come back anywhere.
Okay, another question is, what are the limitations from the patient standpoint of going through a Hipec? In other words, what are the disqualifications?
So really, we have to have a good sense that we are able to remove all the disease. So if the patient has disease outside of the abdomen, so say they have metastasis to the lung, to the brain, to other places outside of the abdomen, then typically they're not a candidate. And then when you focus on the abdomen itself, if we see, solid disease throughout the liver, on both sides of the liver, that we know we're not going to be able to remove, then they certainly would not be a candidate. So we have to assess the disease burden to make sure we would be able to safely remove it. Now, sometimes that can be difficult to do just based on CAT scan, because as I mentioned earlier, the CAT scans can sometimes underestimate the amount of disease. So sometimes we don't know for sure until we get into the operating room. And there are sometimes instances where we get in and we realize that we're not going to be able to do this. And unfortunately, we have to close and stop without really doing much, completing the operation. Other reasons why patients may not be a candidate is if they're too sick for a large operation, if they have a very bad heart, if they have very bad lungs, they have very bad kidneys, and they're just not strong enough for a large operation.
Another question coming in, is Hipec a must with cytoreductive surgery, or could you do cytoreductive surgery by itself? And I guess the question leads to, would the outcomes be different?
Yeah, so the data shows that, again, the hot chemo works best when we can remove all the disease. So there are really no instances where I would go ahead and remove all the disease and not do the Hipec. I have had a few patients with recurrent disease who, went, 8, 9, 10 years after their first Hipec, and maybe we weren't able to get out all the disease on the second chance. But I know that they responded really well to the chemo. So sometimes I will perfuse them knowing I'm leaving a little disease behind. But typically, no. Typically, if we're going to do the procedure, it involves both portions, both the debulking and the hot chemo.
Is Hipec ever used for palliative purposes?
So not typically. I always tell the patients that, they have metastatic cancer. So in a sense, they always have a chance of it coming back. Hipec isn't necessarily a cure. The goal of Hipec is to really increase that disease-free interval from the cancer coming back. If a patient is sort of at the end of their road, so to speak, on their cancer journey, and there were really no options left, Hipec is probably not the answer at that point.
Okay. At this point in time, we don't see any more questions coming in from our audience. Dr. Schipper, I want to thank you very much for the great Q&A session here. We have one more question coming in now. One more.
No problem.
Okay, the question is, why do you decide to close the abdomen and not do the Hipec? I guess you kind of answered that a little bit.
Yeah, again, it's unfortunate when that happens, and it doesn't happen often, but there are occasions where, again, the CAT scan might underestimate the amount of disease, and typically it's the small bowel that would cause that to happen. I can take out a lot of organs. There's a lot of things I can take out to get to that R0 resection, or removing all the disease. However, the one thing I cannot remove completely is the small intestine. If I remove a patient's entire small intestine, that's not really compatible with life. So there are times when we would get in and find that the entire small bowel is just densely covered with cancer. in those situations, I know I can't remove all the small bowel, and I'm not going to be able to remove all the disease. So at that point, sometimes we will stop because we know we're not going to be able to help that patient, unfortunately. But usually, if it's anywhere else but the small bowel, we can be very aggressive, and we still can remove a fair amount of small bowel, but we cannot remove it all.
Okay. Okay, Dr. Schipper, doesn't look like we have any more questions. As far as the audience is concerned, if you would like to request a conversation with Dr. Schipper, go to hipectreatment.com, click on Connecticut, and you will see Dr. Schipper's profile. Click on his profile, and you can arrange a conversation at your desired time with Dr. Schipper. Dr. Schipper, I want to thank you very much for your time. Great answers to the questions from the audience, and we look forward to doing this again sometime. Thank you.
Thank you very much for this opportunity. And thank you very much to the patients out there for their time and listening, and certainly happy to answer any questions in the future if you have. Thank you.
Thank you.